Bit of a backstory, I was a football player, and shortly, maybe a year or two after I stopped playing football, I had a insurance physical actually, and I came back and had really bad results. I had metabolic syndrome, and I was very confused as to why I had metabolic syndrome, having spent my entire life as a serious competitive athlete. And so I did a little bit of research into the subject, and I found that it's actually very common for former football players to have metabolic syndrome, or not former, actually current football players to have metabolic syndrome while they're playing football. But that was the extent of the research.
Metabolic syndrome is a potentially life-threatening combination of high body fat, blood pressure, and blood sugar with increased levels of bad fats, like cholesterol in the blood. This disease significantly increases a person's risk of heart disease, stroke, and diabetes. It's becoming more common due to the dramatically increased rate of obesity, yet it's not uncommon for people to be totally unaware of this silent killer.
People had done the test, said, yeah, this exists, and then there was no attempt to follow up, explain why, understand the consequences of it. It's just, yeah, these guys are messed up, and we're just going to kind of let it ride. And so I was really, I looked around at all my teammates who were struggling with weight issues after they stopped playing. I'm really concerned about their health. And so I was really inspired to try to go out and figure out what's causing metabolic syndrome in these guys and what are the consequences of it.
His questions about metabolic syndrome brought Mike to Dr. Kevin Neiswander, a physician scientist at Vanderbilt University. Dr. Neiswander has spent much of his career trying to understand what causes our normal metabolism to be thrown out of balance.
First year at the time, now second year medical student, you guys may know him, Mike Powers, approached me with a really interesting sort of translational research idea. And Mike is a real thoughtful and very well organized guy, and the research idea was really intriguing. Best ideas and the best science that's potentially going to impact outcomes in people comes from observing outcomes in people, whether they're good outcomes in people or bad outcomes in people. I think physician scientists gain a very unique and valuable insight into pathophysiology and into the biology by taking care of patients with disorders that they're interested in studying. For me, the best part is developing relationships with my patients and trying to understand what their struggles are, and then taking those struggles into a scientific context and putting a scientific question onto that.
Nothing would happen without the team. That's all there is to it. The physician is important to identifying the clinical issue or the medical driver of the project and developing a protocol that will investigate that in a thorough manner. But an idea or a protocol on a piece of paper is a couple hundred to 1,000 hours away from being an actual set of results. And so without the team to support you through, in clinical research you have recruitment, you have the actual execution of the study, you have preparation for each day of the study.
An important part of any clinical research team is the group of people who interact with the patient in the clinic, including specially trained research nurses. Antoinette Richardson is a registered nurse who has been working with Dr. Neiswander for years to help bridge the gap between patients and scientific discovery.
Most nurses in their usual practice, they don't know what research is. It's something very vague, what is research? What are you doing? And they think that it's just something that doctors do or some laboratory somewhere down the hall in another part of the building. But when I came into research as a nurse, clinical research, and it was in diabetes, and it was up in Indiana, I was amazed at my responsibility, but amazed at the whole clinical research arena.
The physician may not be the best person to write an IRB or prepping test tubes. It has to be done, and it has to be done properly, because if it's not, when things are sent to the lab, if they're not labeled properly, they never come back. And and getting the nurses in, and the coverage, and also recruiting people.
I coordinate studies. I recruit individuals for the studies. I also do regulatory. There are, in order for studies to start up, you have to have IRB approval and so forth. And so I have a role in that. Once studies do start, recruiting and management of the patients that come into the study, as well as the study days and the follow-ups.
The physician who comes up with the idea or the issue that needs to be researched and designs how to research it is of vital importance, because that's the playbook off which the team operates. But at the end of the day, no one person could do all of this work. There's thousands of hours between a document, between a proposed research project and an actual set of results. And it takes a lot of people with a lot of different areas of expertise.
The other one about 80 yards. Okay, we got 173 yards of offense.
Every member of the research team brings their own skills, knowledge, and curiosity to bear on difficult challenges. As team leader and mentor, Dr. Nicewander helps connect the people who are asking important questions to the resources they need to discover answers.
So I think I view my role as a catalyst. So I have a lot of clinical experience, and I have a lot of scientific experience. I see and I hear a lot of different things, and I see and hear a lot of different ideas out there. And what I really like to spend my time doing is kind of thinking about that and synthesizing that and figuring out where two ideas that at face value are very, very different, where they might intersect and overlap. I spend a lot of time around this institution, and I think about ways of knowing what all the resources here are, is how to jumpstart projects, and how to put people together, and how to generate synergy and ideas, and apply sort of new questions to old ideas, and old ideas to new methods, and that sort of thing. And so bringing kind of different ideas together.
So I do a lot of things, kind of working on projects a lot independently, but he gives us a lot of guidance as to, specific metabolic questions, things we should be addressing. So him and I kind of interact more on a senior level, where I'm kind of, doing the day-to-day stuff and directing that, but then when it kind of comes to the concepts and the ideas and hypotheses, we work together.
He's been a fantastic mentor in terms of helping me develop the protocol that's necessary to really dive into the underlying causes and the mechanisms of metabolic syndrome in this population, and also teaching me how to write the grant that I needed to do the study. We spent, I think, about $85,000 looking at this, and writing the IRB and all these other things, and linking me up with research nurses who have expertise in the hands-on sort of nuts and bolts of making a clinical trial happen as well.
A football player depends on his coach's knowledge and experience to develop a game plan for success, and then on his teammates' talents to execute that game plan. In the same way, Dr. Nicewander's perspective and the cooperation of various members of his research group work in concert to successfully answer difficult scientific questions.
In the case of this project, I was a former football player, so I could go in and talk to football players and say, hey guys, this is my life experience, this is why I care about you, this is why we're trying to get this done, and they could understand that narrative, and they came and were willing to participate. It wasn't that I came in like, I want to be a great researcher. It was, this is an issue that nobody's looked at, or people haven't looked at properly, and it needs to be addressed.
The challenge of it is really what keeps me going. I come to work every day and I'm constantly challenged. It's very difficult work, and it's hard to figure out, and that's what I like about it.
I've just always been really interested in the actual science of it. So one of the reasons why I became interested in circadian rhythms, it's one system where we know the exact region of the brain that controls an exact behavior. So we can take that region of the brain out and put it in a dish and record rhythms, and I can do things to the mouse and manipulate the light dark cycle or give them diet, and I can directly correlate it back to the brain or to a tissue. And I always have thought that's really fascinating.
Same.
So
It's everything's sort of just a huge puzzle that you get to always figure out. I mean, every day there's always a new thing that you get to kind of tackle and figure out exactly either what's happening or what's going wrong. And either way, it's still really enjoyable and kind of keeps you thinking and keeps your mind going. And then, I mean, what really got me into it to begin with is I just like technological stuff. I mean, technology is fun, and the idea of like using a giant magnet to look at people's brains and see what's happening within them was reason enough for me to get excited about it. And then once I figured out how involved it was, I mean, it just like an endless like path of discovery.
Where we're now trying to take ideas and intervene at population levels and in communities. There's a big role for PhD sort of behavioral scientists, but there's a big role for MDs as well, who really, because of having a clinical practice experience, understand human behavior and what some of the barriers are to invoke behavior change in patients. So that perspective of trying to synthesize the human condition and try to understand new ways to tackle that problem and that question, I think is what a physician scientist brings to the table.